Good morning, everyone. Today we have the pleasure to have with us Dr. Philip Dockery from Arkansas, and he will share with us the experiences with the corneal allogenic intrastromal ring segment implantation, which is a new alternative and a very appealing one to use corneal tissue segments, which are better tolerated, and they are showing very promising results. So welcome, Dr. Dockery. Thank you again, and please go ahead.
All right. Well, thank you for that introduction. Again, my name is Philip Dockery, and it's my pleasure to give this talk. And it's called A Practical Guide to CAIRS, or Corneal Allogenic Intrastromal Ring Segment Implantation. I have no financial disclosures related to this talk. So I'm just going to kind of back up, talk a little bit about keratoconus first. So keratoconus is a non-inflammatory progressive disease that is characterized by thinning and steepening of the cornea. Often you see these progressive optical obscurations that lead to decreased visual acuity and polyopia in eyes, people complaining of multiple images overlaying each other. So here are two Pinacam images that display kind of late, moderate, early advanced keratoconus. The top one is a corneal thickness map, and you can see the central cornea is a little bit thin, around 455 microns. And the lower image is one of the axial curvature that shows a maximum keratometry of around 57, 58 diopters. So you see this central thinning and this infratemporal steepening of the cornea. And so what was the typical traditional approach to treatment for keratoconus? Well, it was penetrating keratoplasty. Penetrating keratoplasty is done by removing the central cornea and replacing it with an allograft donor. And so that provides for a more flat central cornea with better optical clarity. You then use sutures to hold this graft into place. And this was the standard of care for decades for keratoconus, as really the only definitive treatment for it. This is still used in cases with central scarring or very advanced disease. It does come with a myriad of complications, such as graft rejection, allograft reaction. These are often young patients that have to be on steroids their entire life, and often multiple grafts. There's also suture-related complications such as abscesses or cheese wiring, or even angle closure glaucoma as a result of too tight of a suture. You can also see graft dehiscence after trauma. You can see steroid complications such as cataracts and glaucoma. And you can even see disease progression in eyes, particularly with people who continue to rub their eyes after transplantation. So as you can see with this myriad of complications, it's providing other minimally invasive alternatives for the treatment of keratoconus can be dramatically beneficial for these patients. So earlier this century, a new procedure called corneal cross-linking was developed. And essentially what that is it halts the progression of disease without any real surgical intervention. All you do is you apply the riboflavin drops, and according to Dresden protocol, it's applying the riboflavin drops for 30 minutes and then applying ultraviolet light for an additional 30 minutes. And what this does is it provides cross-linking, which stiffens the cornea and holds it in place. And by stiffening the cornea, you can halt this visual deterioration and reduce the need for corneal transplantation. It has incredibly great success. Over 90% of patients are able to avoid further treatment after receiving cross-linking. However, I do want to point out that all it does is it halts the progression of disease and does not improve disease. So that's where we get into other types of treatments that provide a better visual improvement. Intracorneal ring segment implantation is one of those things. It's a minimally invasive treatment that polymethyl methacrylate or plexiglass segments can be implanted into the paracentral or peripheral cornea that then push that cornea a little bit outward and provide a flattening of the cornea centrally, allowing for a hyperopic shift, which allows for better visual acuity in patients with keratoconus. And so essentially the way this works is you take these segments and they are put in the peripheral cornea here, and you can see the flattening. and it does reduce corneal curvature and improve visual acuity. But what about outcomes of intracorneal ring segments? And here you can see some topography images of this same eye that I showed you on the first slide, and postoperative after intracorneal ring segment implantation. You can see a flattening of the cornea and even possibly a regularization of the astigmatism slightly improving. And you do see an overall flattening of about 7 diopters right where the segment was placed. And so this seems to be very good outcomes for something that we would see with intracorneal ring segment implantation. And typically we see around 2 Snellen lines of corrected distance visual acuity with this surgery, some less, some more, but that's usually about the median that we get from it. Here are some pictures of intracorneal ring segment implantation in an eye that was very successful. This picture is a little bit out of focus, but over here you see it more in focus. There's very little inflammatory debris around it, and here you can see the radial incision with some epithelial, with kind of a little bit of epithelium over the top of it. However, you do run into complications with Intacs. If people continue to rub their eyes, you can have segment migration, and here's a picture of that. If they rub their eyes very vigorously, or if the segments are placed too superficially, you can see segment extrusion where it comes through the anterior cornea. You can also see neovascularization around the segments in some cases. And then even worse, in cases of segment extrusion or dehiscence, you can see secondary bacterial keratitis, which then forces you to explant the segments, treat the keratitis, sometimes even leading to penetrating keratoplasty. And then also you can run into intraoperative complications such as corneal perforation, as seen here. And so what can we do to eliminate these complications and then also provide the visual improvements that you see with Intacs? So that's where CAIRS comes in. So corneal allogenic intrastromal ring segment implantation. Essentially, it's the same procedure as Intacs, except instead of the synthetic ring segment, we're using allogenic donor stroma. And so these are harvested from a donor, just like you would from a PK or a DMAC or a DAUC, but they are in small strips of peripheral cornea, and then they are inserted in this lamellar channel, just as an Intac segment would be. And so this surgery was developed in 2015 by Susan Jacob, and it was introduced in this paper in 2018. And as I was discussing, this is how they are harvested from a donor cornea. It's with this special trephine that comes in 2 different shapes. One provides thicker segments and one provides thinner segments. And you see this ring that is harvested, and then you can cut it into 2 and then insert those 2 segments into the intrastromal channels like you would in Intacs. The original technique was done by using a femtosecond laser to create the channels. And because it was done typically on more mild disease, not only did they use the thinner segments created by the larger trephine, but they also cut them in half so that you got very thin segments so that they were very easy to slide into the channels. And because this was done in India, you could also do cross-linking on the same day of the surgery. So these segments were stained in riboflavin, which not only assisted with cross-linking, but also aided in visualization. Originally, these segments were attached to an Intac segment, which was threaded through the channel and allowed for almost like a train to pull the segment through once you got the Intac segment through. However, this technique is no longer used by Susan Jacob. She now just pushes it through and then pulls it through on the nasal incision. But that was the original way of getting the segment into the channel. And so what were some of the outcomes of this? So in that paper, you saw 24 eyes with a median follow-up of 12 months. And these were some of the most significant metrics that we saw improvement in. So undercorrected visual acuity, corrected visual acuity, we saw about 2 to 3 lines of improvement. And then spherical equivalent was significantly improved, about 4 diopters, astigmatism mildly improved, and you did see flattening of maximum keratometry and the mean corneal power on topography. And so this is very promising results with no complications observed in this follow-up period. So this really shows that it's doing what this surgery was designed to do, provide similar outcomes to intracorneal ring segments without the complication profile seen with that surgery. However, what if you don't have access to a femtosecond laser? Or what if you're in a place where protocol for same-day cross-linking isn't really allowed? So this initially introduced protocol may not be something that is plausible or even feasible at your institution. Well, that's kind of what we ran into at Parker Cornea. And so it was developed in 2019, but introduced in 2021, a manual method for CAIRS implantation. We titled it Flatten the Curve just to correspond with the ongoing pandemic because of flattening the curve of coronavirus. And so here are some images just to briefly describe the channel formation in manual Intacs implantation. It's very similar to intracorneal ring segments, if anyone has ever done that. Essentially, we are marking the cornea. We dry it first, we mark it with a crosshair, we use gentian violet to mark the center, and then mark where the channels will be formed. And here in what is labeled D is the first difference between intracorneal ring segments and CAIRS. So intracorneal ring segments, we normally set the depth of this guarded diamond blade to around 80% depth. But in CAIRS, we will set it to about 60% depth. And that's because we want to put the ring segments in the mid-stroma, so around 50%. So if we set it to 60% depth, we know that the actual channel will be slightly more superficial than that. So we'll achieve the target depth of around 50%. We'll then put on a vacuum pump and then use a pocketing hook to open up a space and then slide through this blunt semicircle to create these semicircular canals with blunt dissection. And then here is also a very different part from intracorneal ring segments. So for Intacs, we will do one incision, but for CAIRS, 2 incisions is required. So we do one 180 degrees apart from the initial incision. And we usually do that around 50 to 100 microns deeper than the first incision, because 1, the nasal cornea is typically a little bit more thick. And 2, we want to make sure that we make a connection between these channels that are formed and the new incision that we make on the nasal side. That being said, we no longer always do nasal incisions and temporal incisions. We will sometimes try to line up the segment with where the cone is most prominent. So sometimes this temporal incision will be slightly more superior, sometimes it will be slightly more inferior, so that the segment is placed at the most prominent portion of the cone. And so here is a demonstration of how these Intac segments are implanted. And so really there are a couple instruments that you want to be able to have. So really forceps of any type where you can use small forceps to try to push the segment initially into the channel. Initially, we were using a bent Y rod to try to push the segment in through the first half of the channel, and then using a reverse Sensky hook to pull it through. However, we found more recently that using a reverse Sensky hook to both push it in and pull it through is a little bit more successful, is a little bit gentler on the wound as well. And so one little tip as far as using the reverse Sensky, you see in this image, the knob is pointed up. That's really our preferred method to try to get underneath the segment and push it or underneath the segment and pull it through the channel. And by getting underneath the segment, you're protecting the cornea a little bit more from potential perforation than if we were going over top and trying to maneuver it. In some cases, we will see this pretty prominent wound gape after we insert the segments. It has improved since we've started using the reverse Sensky for both pushing and pulling through the channel, but sometimes we will still need a segment. And part of that could just be because of these thick segments that we are using to flatten the cornea. It causes such a degree of flattening that it causes these incisions to splay open a little bit more. And then so earlier I talked about the different size tree fines. And so one produces thicker segments and one produces thinner segments. Typically with the manual technique, we've been trying to use the thicker segments more because often we are treating advanced keratoconus with this. You see these segments are bright blue. And so that's because we cannot use riboflavin for our staining because we cannot do cross-linking on the same day as CAIRS implantation. So we use trypan blue to stain our segments. And so here is a picture of one of the first operations done in America where the segment was unstained. And as you can see, it's very difficult to see. It really blends in with the cornea, and it's very tough to tell how far it has progressed throughout the channel. And here is one of the first surgeries where we stained it with trypan blue, and you can see the visualization is much more improved. However, it's very heavily stained. It kind of bleeds into the adjacent cornea, and it's very soggy when you add this trypan blue initially. So we thought, well, is there something else that we can do to help ease implantation? So that's where we've also developed dehydration of the segments. So dehydration of the segments usually takes around 20 minutes after just exposing it to free air in the operating room, and those segments will dry out. Initially, we put them on a Wexel sponge. However, we did notice that sometimes the Wexel sponge can flake off a little bit, so you will have small little white flecks around the segment. So we've been recently using a Maricel sponge. And then so what that does is it provides a very thin segment, even if you're using a thick piece of tissue. So you can put in this dehydrated segment easily into these channels. And then as this segment rehydrates, once it's within the cornea, it becomes thicker, providing for even more flattening. And so here is an example of that. Here we can see a preoperative image of axial curvature, and the Kmax is in the upper 80s. One day postoperatively after CAIRS, we see the Kmax reduced down to the low 60s. And here is the difference map of that axial curvature. And we are seeing 24.5, 25 diopters of flattening. And just to compare that to intracorneal ring segments, this is a great case of intracorneal ring segments where we saw 7 diopters of flattening. CAIRS, we are receiving 24, 25. We've seen up to 36 diopters of flattening in very advanced keratoconus. And we are seeing lower improvement in milder keratoconus. But this just seems to be a phenomenal surgery, even for eyes that are with very advanced disease. And so here is 2 Scheimpflug images that I've overlaid. The red image being prior to CAIRS implantation, and you can see this visibly ectatic cornea. And the green Scheimpflug image is after CAIRS implantation. Here, these hyperreflective areas are the actual segments, but you see this prominent flattening, and not only flattening, you can see a regularization of the shape, which likely provides much better optical quality. And this patient, I believe, improved from something like 2200 down into like 2030, 2040, just with this surgery. And so now I'm going to show a little video. All right. So this is just a video of CAIRS. And as I was discussing earlier, we dry the cornea and then mark it with these crosshairs. And then we use Zinshan violet to mark the center of the cornea right at the visual axis. And then we will mark with Zinshan violet to show where we need to make the channels. We use a guarded diamond blade. And essentially what I'm showing here is we have already marked, or we've already measured the central corneal thickness with a handheld pachymeter prior to the surgery. And so we know about where we're going to make the incision. So we measure it at that point, and then we'll set it to about 60% of that measurement that we made just prior to the operation. And so we set that and we make a single incision right along the line there. And usually it's a little bit more temporal. However, sometimes we will shift it up more superior or sometimes a little bit more inferior. And then we use a pocketing hook to open up these areas where we can allow for these corkscrew blades to come in. Then we can use the corkscrew blades, and I say blades, but these really bluntly dissect a channel. All it does is it spreads along the lamellar planes to try to keep as much corneal structural integrity as possible. And so this is done both ways. But just like intracorneal ring segment implantation, if you only want to put one segment in, that's feasible as well. Many of our eyes, we only have one segment in for CAIRS. And then you make the second incision. And again, that incision is about 50 to 100 microns deeper, just depending on what we think is the depth in that area. So if it's someone with a little bit milder disease or they have a significantly thicker nasal cornea, we can be a little bit more liberal with our depth of incision and go a little bit deeper. Or if it's a fairly thin area, then we may want to go about only 50 microns deeper, just to make sure that we don't perforate through the cornea. And then we just use a Sinskey hook here just to make sure that there's a connection between that nasal incision and both of the channels. And then here you can see this dehydrated segment. It's very thin. Usually you can see it's pretty rigid here too. So it's easy to just insert into the mouth of the wound with forceps. Sometimes you can even insert them a little bit farther than that. And then in this video, we used a bent Y rod, which you can use, but we've found a little bit more success using a Sinskey hook on the first half of this insertion rather than using a bent Y rod. And what I do want to point out is just how much easier it is to see this segment during this operation compared to the unstained segments, and then also compared to the non-dehydrated segments. And so because we use the dehydrated segments, we're able to put in very thick segments, which provides for such great flattening. And then once you get this segment pushed about 50% of the way through the channel, and even the tail end pushed into the wound, then you can take the reverse Sinskey hook, go underneath the segment, and just pull it towards the nasal wound. And once you get the segment into a proper place, then you can insert the segment on the other side. And I'm just going to skip through a little bit on this part. And so once it's through 50%, the reverse Sinskey hook is then used to pull it into final location. And as you notice here, you do see some wound gape. So a stitch Tenno nylon suture is used to help pull these into place and really provide a great final outcome. All right, so here's just a few videos. Here's that video if you want to hear a commentated version of it with narration. If you're interested in femtosecond laser CAIRS, here's a video that's done by Susan Jacob. And then also here is a CAIRS film that was presented at ASCRS that really talks about the invention of CAIRS. It talks with Susan Jacob, talks with Jack Parker about their developments for not only developing CAIRS, but also continuing to innovate CAIRS and how it has helped them. And then it also shows a brief demonstration. One part of this talk is wanting to be very practical. And so if you're seeing this, wanting to do CAIRS and implement it in your practice, what type of instruments that you may need or what type of equipment you may use. And so the first part is really those intact types procedures. So all of the instruments to form the channels and allow for manual dissection. And here are the instruments that we have used. I'm not sure if the prices are different now or if they are different if you get them from a different company, but these are the products that we use to create the channels, have the vacuum guides, and then using like the Sinskey hooks and all of that. So here is an itemized list of winch instruments that we use. And here is the vacuum system information on this QR code as well. Now, the most important part of CAIRS is the MODU segments, the CAIRS tree funds. And so when I was talking about the two different sizes, so the ones with the smaller diameters, you can see is a greater difference between the inner and outer blades. So it has 1.5 millimeter thick segments. And the ones with the larger diameters have 1 millimeter thick segments. And so these can be used for milder disease, and these can be used for more advanced disease. And if you have very mild cases, you can do as Susan Jacob did in her videos and in her initial surgeries, where you even take these segments and then also cut them in half to allow for easier implantation. We've found success with using these thicker segments, not cutting them in half, but dehydrating them to make the segments seem thinner during insertion. and then implanting those thicker segments, allowing them to swell after being in the cornea. And then so really just some conclusions for this talk is CAIRS is a very minimally invasive treatment. It's something that is not only able to be used for mild and advanced disease, or for mild disease, but we can even use it for advanced disease. We've used it in corneas with the Kmax of over 90. We've seen fantastic outcomes. We've been able to get patients back into scleral contact lenses or back into normal contact lenses because of just the tremendous flattening that we see with this. And when we combine it with cross-linking, we're hoping to prevent keratoplasty, prevent having to do these full thickness cornea transplants in these young patients. We've really just seen a very low complication profile. We've done about 80 cases, and we've seen one allograft reaction, which we have used some steroids for about a month. We've seen, but other than that, very few complications. So overall, it's really a great surgery that provides this minimally invasive option for people with mild to advanced disease. So any questions about CAIRS?
Yes, Dockery, I have some question for you. The first is, how thick is the implanted segment that you take from the cornea?
Here are the tree fines. And so these tree fines you see make a loop. And so typically we will cut these in two. You can see how Susan Jacob does it. She will cut it in two, insert those, and then sometimes trim off the end. What we sometimes try to do is trim it just slightly shorter than half of this circumference. And so you can easily insert it into the semicircle in that half of the cornea. And so the diameter is really dictated by these tree fines, because they are the ones that make the tissue, these segments.
Yes, and Dr. Dockery, the depth of implantation is about 70% of the corneal thickness.
So that is more of the, so 70% is the goal of the target implantation, typically for intracorneal ring segments. So Intacs, Ferrara rings, things like that. But for CAIRS, we try to put it around 50% depth. And so when you're using a femtosecond laser, you set it for 50% depth. However, we've noticed when we do manual implantation, things end up slightly more superficially than the guarded incision that we make with the diamond blade. So if we're shooting for 50%, we try to make an incision of around 60%. And what that does is it allows us to, when you make that groove with the pocketing hook and when you are inserting those corkscrew blades, they are just ever so slightly more superficial to the deepest part of the wound.
Well, another question for me. A very nice allogenic technique using a corneal segment. But the thing is, if you have a double incision, you can use a pigtail instrument to play the shooter in the tunnel, move in 180 degrees, and then with the shooter, the segment and move the segment in all the 180 degrees. And it's easy because for me it's very difficult to move the segment in the middle of the tunnel with the instrument.
Yes. So I think that same sentiment was the reason that the segments were originally pulled through using an intact segment. Right near the center part of the tunnel is the most difficult place. We found a little bit more success using a reverse Sinskey hook to push the segment and pull the segment through, because we have a little bit more maneuverability than we do with the bent Y rod.
Thank you.
And one other thing I do want to mention, I didn't put it in this presentation, is that for one option is to get these tree fines, but also the Alabama Eye Bank does prepare them themselves and send them to people. So you can buy them directly from the Alabama Eye Bank if you don't want to prepare the segments yourself.
Morning, Dr. Dockery. So thank you for your talk, first of all. There's a couple of things I want to know. After you dehydrate the segments, have you had any tears in the segments while pulling them through the channel?
No, we've never had the segments come apart. We may have had like at the very end, like small little fragments pull off, but we've never seen just the segments pull into two large segments or anything like that.
And when it comes to post-operative care, have you had any issues like regarding immune suppression they have to put your patients through or something like that? Can you talk to me a little bit more about post-operative care?
So for post-operative care, we use very similar to cataract surgery, antibiotics and steroids. The steroid regimen that we use is a little bit more than cataract surgery, where it will be anywhere, we've tried it anywhere from 1 month to 3 months and had really great success with all of them. We've had one episode of allograft reaction, but that was treated very easily with a brief course of steroids. We will typically treat around 1 to 2 months with steroids and then also do antibiotics on top of that for about a month.
And after tapering down the steroids, like you just leave them steroid-free for a while and then
Yes.
usually good.
Yes. These are very small segments when you think about it compared to like a DALC or a PK. And so these segments, there are very few antigens, so much less likelihood of rejection or allograft reaction. We've only seen one case of allograft reaction. We've seen no cases of rejection. And the thing is with it, it's like even if there is a little bit of allograft reaction or haziness with the segment, it's not within the visual axis of the patient. And so you have a little bit more time to be able to figure out what it is and be able to treat it without affecting the patient's vision.
Thank
you. Dr. Dockery, thank you again for your excellent presentation. Really, it is very impressive, your very nice results. The amount of flattening, as you indicated, is really very, very significant. So we have had some experience with intracorneal segments with synthetic material, but we also have had complications. We remember a case of a late infection in a physician, and it was a really challenging case. And therefore, we are using much more corneal cross-linking than intracorneal segment rings. But now with this option, which is much more safe, and it seems to be much more effective, no doubt we will try it. So thank you a lot for all your thoughts that you have shared with us, and also for the details about the where we can get the instruments and everything. Thank you again.
Yeah, of course.
Okay, Dr. Carreño, he has a question. Dr. Nestor?
Hi, doctor. We use nomograms for intats or Ferrara rings. Do you have nomogram for these kind of segments?
We do not. I think that at this point in the game, it's still very early with this surgery. I mean, fewer than 200 CAIRS operations have happened internationally. And so developing a predictive nomogram for how to do it and when to do it we just don't have the data published on that yet. And so we've found success being able to use CAIRS implantation and all varieties of keratoconus and just kind of tailoring the segments for each person's disease, just kind of up to clinical judgment at this point. However, we're hoping to be able to analyze some of our results and get back to you on like what type of segments are best used in what type of eyes, maybe in the somewhat near future.
Okay, so Dr. Dockery, thank you again, and we will let you know our advances using this technique.
Well, I would love to hear about it.
Yes, so thank you again. Thanks everyone for being here, and have a very nice day.